Hi everyone, Melanie Grant here. This video is recorded for my Reimbursement Management Methodologies class on Chapter 7 of our book, Medicare Hospital Outpatient Payment Systems, or OPPS, where we're going to talk a little bit about how Medicare makes payments for outpatient services. As you can see here, we're going to be using the PowerPoint that goes along with the AHIMA Principles of Healthcare Reimbursement and Revenue Cycle Management book with Chapter 7. This is the 7th edition. To get started, we're going to look at specifics in outpatient healthcare systems, and it's all going to look a little bit confusing, especially if you've never done this before. The biggest thing I can say is that as we go along, take reference of the different areas that Medicare provides different types of payments, but keep in mind that depending on where you're working and what kind of billing office, only one or some of these are going to apply to you. Medicare does a lot of what we call bundling and packaging with their payment systems. They also look at the different types of services based off of the HCPCS level 1 and 2 codes, or CPT and HCPCS code books, respectively. And they utilize that plus various factors like where you live and what type of facility you are to determine an overall package and payment system. We're going to look at that in detail, but take it with a grain of salt in knowing that which one applies to you will be the one that you'll be most familiar with. So the first thing we have to look at is some of our definitions. We see here that the Medicare Outpatient Prospective Payment System, also known as OPPS, typically don't mind the PowerPoint spaces on abbreviations, because OPPS is something you'll find together on several different documents as one abbreviated term. And this is going to refer to really all of your outpatient services. You have examples here of the hospital outpatient, such as your clinic, emergency department, and ambulatory surgical units, or basically parts of the hospital where a patient is coming in for services or surgeries, but they're not considered inpatient. They're not staying for an extended period of time. This may include, however, some of the inpatient services or ICU care, so they may be there overnight in some of these settings. This is updated yearly, but you'll also notice that some of these payment systems are updated quarterly as well. There's 3 different main types here. We have a fee schedule payment, which looks at things like ambulances, physical therapies, DME, prospective payment systems, which look specifically at the classification of basically what type of facility are you, where are you located, and what kind of bundling or package service applies to you. And then reasonable cost payments, which looks more at your pharmaceuticals or your vaccines and says, what is a reasonable cost to reimburse you, not to make money off of this particular item. And we'll look at each of these in a little more detail as we go along. Under the ambulatory patient classification, or APS, this identifies the type of patient you're working with to determine the type of payment system you're under. This looks at certain groups like the procedures itself that the patient is getting. So it's still looking at more of their services themselves rather than, geographic information about the patient. We look at procedure codes for this. So your CPT or your HCPCS codes, which are all bundled as HCPCS codes, but can be defined as one or the other. The other thing is to keep in mind is that unlike an inpatient payment system or the IPPS, the outpatient payment system under ambulatory patient classifications does not look at diagnostics. In fact, they look at 2 main things, either packaged services, things that would go together and that are commonly seen at the same time, and bundled services, things that are related to each other and should be considered part of the same payment when done together at the same time. We have 2 different areas that we can look at for what this actually looks like in real life. So I'm going to pull up examples 7.1 and 7.2 from the text. So as you can see here, example 7.1 has an example of a patient coming in for an MRI. This patient receives the MRI with contrast, which is the fluid that's injected into their body in order to make them glow or respond on imaging. And there's a code available from both the CPT code book as well as the HCPCS code book for each of these items. The MRI lumbar spine with contrast is identified for the service itself and indicates that contrast is included. The Q code found in the HCPCS code book is used in order to report what type of contrast we used. But you'll see here that it's considered a packaged item. And so because the CPT code for the service itself included the contrast, a total payment is made for both the service and the material used of $381.85. The Q code is listed for reporting services. This is done really for data collection and so that we can reference what kind of contrast is most likely used, if there's complications later. There's so much research that's being done constantly on medication and medical services to see their effectiveness. So this is very important that it's listed, but not paid because it's packaged in the original service. Separate of that, we see here on this other one, an example of a bundled service. So example 7.2 has a patient also coming in for an MRI without contrast, you'll notice. And the MRI is going to be of the cervical, thoracic, and lumbar regions. So they're looking at the entire back. You have here an APC, which is going to combine all of this service into one payment for each of those 3 MRIs. So instead of receiving a separate payment like we had here on the MRI of the lumbar spine, we have each of these CPT codes listed and a total payment reimbursed for the total APC. This is considered a bundling service where they took all 3 components of the same MRI and said you came in at the same time and received the MRIs together during the same visit and encounter. The patient may have been moved at some point, but is still the same providers, nursing staff, and most likely the exact same equipment to provide the same MRIs. So they get reimbursed for 1 payment rather than 3. Now, we also have what's called a partially packaged system. A partially packaged system is more for your hospital, not inpatient units. And it's really identified to help our hospitals to be mostly cost efficient, as well as providing services that are really just the best value. There's a lot of controversy on what services should be done for what items. And so Medicare does their best to curb the extensive cost of healthcare by providing flexibility, but more incentives towards cost-efficient areas. It allows providers to have the ability to really say how they feel they should treat their patients while making sure that we're not paying unnecessarily. Most of the time, you'll see these things in a partially packaged system where the provider was able to do the additional service and get paid the additional or paid the same amount if they did or didn't do it. And the idea behind that is to provide everything that you need to your patients without increasing the cost for what you could have done with less services. We're going to look a little bit at what this looks like. There we go. The way that they identify this is through what's called a payment status indicator, or SI. And again, we have those little spaces which can be confusing on the PowerPoint, but don't let that throw you off. A status indicator is going to be listed on your fee schedule or APC, and it's going to give you information about the patient's services themselves, if they're allowed, or what type of services that they are. We have a table here, 7.1, which lists all of the payment status indicators that were identified when this publishing came out in 2020. The main one that you'll be familiar with in an outpatient setting is a status indicator of A, which simply means that there's a fee schedule payment for that particular code. And you would want to find the fee schedule payment to determine how much you will get paid. We're going to look at this in a lot of detail, but you can see that there's several different payment status indicators in this table. Most of these are going to just identify things like what type of service you're under. And so you'll really just kind of be under the same one or two payment status indicators for most of your services. However, if you're doing something that is typically an inpatient only service, you'll see that the code, when you pull it up, it has a status indicator of C. As an outpatient provider, it's very important that you're familiar with that so that you're not doing that service in the wrong location. There's a lot of reasons for that. Primarily, it comes down to services that are more major, like major surgeries, should really be in a setting that is able to provide services if a critical injury were to occur or the patient needs additional recovery time, not typically provided in a same-day surgery unit. When you're looking at these, there's a few things that you'll want to look at to determine the status indicators. And again, don't let that space throw you off here. The first thing is going to be your HCPCS codes or your CPT codes. Remember that CPT is level 1 versus level 2 of the same classification system. So if you're not familiar with coding as much, this would be a great time to just brush up a little bit on what's the difference between a CPT code or a HCPCS code, known as HCPCS. When these status indicators are assigned, this is basically saying we can go to CMS's website and pull up the information based off of the CPT codes or HCPCS codes in their fee schedule. This is going to be released every year, but it's also updated every quarter. And the reason for that is because things change. As we've seen in recent years, sometimes healthcare concerns change rapidly. And sometimes some of the procedures that we find that are done for new technologies may change the way we do medicine. Now, the part that's going to be identified as we go along is how we use those status indicators to determine reimbursement. So when there's multiple codes reported, which does happen commonly, you'll notice that there's multiple status indicators on each encounter or visit with the provider. Some of these are going to be bundled together, and some of these are going to go against each other. So it's important that we look at them to see what's included in each status indicator. The first thing to keep in mind is that each HCPCS only has one assigned APC. So if we go back to our figure 7.1 in the text, we'll see what this looks like. An APC of 5021, which is listed on the visit itself. So this is somewhere in the system saying what kind of APC is it. It's going to indicate all kinds of information about a patient coming into the office. We have the payment status indicator for an ED visit type 1, something called a relative value or relative weight, a national adjusted amount, a national copay amount, and a minimum copay amount, all for this one CPT code. We're going to break this up and see exactly what this means. Now, when we talk about relative value, our first term here, or relative weight value, this is the measure of resource consumption. And so what they're talking about when they say resource consumption is they're talking about in your area, the resources that are needed in order to provide this service is given like a number where it's weighted. So if you ever think of a grade and how your grade is, 10% off of one thing, then that's a 0.1 of a whole. And so we talk about decimals and numbers. So this is 0.86 or 86% for the relative weight of the area that the patient is in. The national unadjusted payment amount is the total amount when we take that 6962 and multiply it by the relative weight. And then we look and see if there's a copay amount for this service. All of this is done in order to make a calculation of what's being reimbursed and how much will the patient pay. Of course, sometimes you're going to come across different APCs that are identified for status indicators that are very unique. And so you have some indicators here for categories of APC payments that are going to be unique with certain types of services. And each one of these, which will identify how we pay them. So we have an example in our text of 7.3 that we can look at here. In this example, a patient is seen for wound care after falling and getting a scalp laceration. The physician treats her wound and uses CPT code 12020. So that's already been done. The physician gives the patient then a lidocaine to numb the area and begins a suture closure. The injection of the lidocaine and supplies required to perform the closure is packaged into the payment for the procedure itself. So you can see here that the status indicator here of T, in, and packaged tells us exactly what's going to be included where. The closure itself is paid at $497.02, and that includes any packaged information like the lidocaine medication that was given and reported with our J code from our HIT book, as well as supplies for the drug itself. So like your needles and, your Band-Aids, all of the small stuff that back in the day, they used to say they'll bill you for a box of tissues. We don't do that. In fact, it's all included in that total payment so that we don't have to worry about what supplies are needed. We just simply provide the service and make sure that we give the best care to our patient. Another type of payment status indicator category is going to be dependent on the type of facility and specifically looking at partial hospitalizations. So depending on your facility or where you're billing for, this may or may not apply to you. But in a hospitalization program where a patient is partially hospitalized, there's different breakdowns or categories of per diem payments under the outpatient setting. Keep in mind that not all hospital settings are considered inpatient. In fact, a patient needs to be in a hospital for 2 or more midnights in order to be considered admitted to an inpatient setting. Otherwise, even though they may be inpatient, they're still considered an outpatient service. To look at this, we break down our partial hospital programs or hospitalizations based off of a patient who's a status indicator of P, or based off of the types of services that they have. Let's look at that. The first one of these is a comprehensive payment system. We have here an all-inclusive APC, which means there's a primary procedure and most of the additional services for partial hospitalization, kind of like in your inpatient setting, is all going to be bundled into one setting. You have status indicators of J1 and J2, which will identify the types of procedures or services done as your king of the status indicators. So your primary comprehensive APC is under your J1 status indicator, while other items may be packaged if billed on the same claim, but are typically considered paid as part of that comprehensive package. To give us an example of this, we have here a patient with various status indicators, and you can kind of see here a claim service with a status indicator information from Addendum B for a patient who comes in for a closed treatment of a metacarpal fracture. That's going to be your J1, your king of all status indicators. That's the main service. The secondary service is also going to apply here, and they have a status indicator of T, meaning that they're not typically going to consider a close treatment of a phalangeal shaft fracture as part of the metacarpal. So in other words, these are two separate services, but because it has a status of T, it's a less procedure and is going to be reimbursed at a discounted rate. The emergency service itself is included in this visit because you would not be getting treatment for a fracture and an emergency visit separately unless it was a separately identifiable service. Likewise, you're going to have an x-ray of the hand, which is considered a conditional package. And so we'll look at conditional packages as something part of that as well. All of these services being related to each other with the exception of the additional surgery, your reimbursement is going to include for each of these items, as you would not have known that they needed to get the treatment of the fracture unless you first saw them and gave them the x-ray. So when it's done on the same visit, they're coming in for one thing. They broke their leg and they need, or I'm sorry, they broke their hand and they need help in order to get back to normal. Which brings us to the claim services and your final APC. So we list the code 26607, which has the APC for the conditional comprehensive payment of 5113, and it considers it as a level 3 musculoskeletal procedure. You get a full reimbursement based off of this. The additional services, which each have their own, ended up being separately packaged. And so even though the phalangeal shaft is separate, it's considered part of the original treatment because it's still part of the same fracture or the same hand break. The ER visit is also considered part of this visit, as is the x-ray of the hand, because it's a comprehensive service and we're trying to reduce additional services. So we get one full bundled service payment for this APC under J1-C APC. Now, if that's not clear as mud, we have different breakdowns of conditional payments as well. Status indicators Q1, Q2, or Q4 each have separate types of payments for what's called a conditional APC payment. Again, this is going to be areas where specific types of services will apply depending on your type of facility. So you'll either always work with these or probably never see them again after this video. We have some examples in our figures 7.3 and example 7.4 of what these look like. So let's go down to these now. So a status indicator Q1 packaging, example 7.3. Similar to above, we have some services that are coming in. This particular patient is coming in for strapping of their ankle or foot, and it's identified with the musculoskeletal CPT code of 79540. At the same time, our office looked to determine if it was broken and used the x-ray of the ankle 73610. This one has a status indicator of Q1. When we get into our claim 1 for the final APC, the provider themselves is going to bill 29540, and they'll get the APC code associated with that for payment of a level 1 strapping and cast application. You'll notice that they have no reimbursement for the x-ray itself because it's considered packaged. But if the radiology service is provided separately, then this would have a status indicator of S. And so this would be the level 1 imaging without contrast. In a lot of times, you'll see where there's modifiers indicated for what's called a professional service. And so the provider may have had the technical component of the x-ray completed, but the radiologist would bill separately for interpreting that x-ray. We also have an example here. So a patient in for Q2, which is your packaged examples under a Q2 qualifier, a patient is admitted to the emergency department for a possible hip dislocation. A hip x-ray with contrast is performed and shows hip dislocation, and treatment is provided to return it to its proper alignment. So this is called manipulation. The hip x-ray is assigned a status indicator of Q2. The dislocation treatment is assigned a status indicator of T. Because the hip x-ray is conditionally packaged and performed with the T procedure, payment is only made for the dislocation treatment. The last one that we have of conditional payments is our laboratories conditional payments. And this is just basically saying that laboratory tests, when billed on the same claim as one of these other status indicators, most of the time they're not going to be payable. However, laboratory does have its own separate fee schedule and can be paid separately. So as you can see, there's a lot of different APC categories. When we look here at this table, it gives us some of those categories by defining based off of the type of CPT code, what type of category the APC is. And this is going to, of course, affect based off of the patient's payment status indicator. Let's look at some of the examples in our textbook to see exactly what some of these procedures look like. The first thing we have is table 7.3, or table 7.2 and 7.3 here. 7.2 gives an example of some of the APC composites for 2020, looking at different types of care. So you can see here like the 5041, 5045, and so on for each of the different categories we were just looking at, identifies the types of services. There may be multiple CPT codes that fall under these services, but the reimbursement is generally around the same. Table 7.3 gives us an example of what category 8004, which is going to be your APC for ultrasounds, will look like. Each of these ultrasounds has their own CPT code based off of where it's located and how detailed it goes. So as an example of this, we have a patient with an abdominal and pelvic pain sent to radiology to receive several ultrasound services. The physician orders ultrasounds of the abdomen, retroperitoneal, and pelvis in the local hospital. All of these radiology services are found under the composite of APC 8004, as we saw above. So there's only one payment for each of these three services. This is also the basis of how Medicare will determine what's called NCCI edits or bundled services. Of course, there's also going to be some services, procedures, and supplies that always have a status indicator of N. So this is the next one that we'll look at. Addendum B would give a full listing. So Addendum B is something that you can pull up to find this. For us, we're going to look at some of these services here under example in the table 7.4. So a status indicator of N, this is going to be assigned really for services and supplies that are going to be bundled. These are always not bundled, sorry, packaged. These are always packaged along with other services. So separate payment would not be made for these when done together. Some of your examples like the anesthesia, repair of a cleft lip, debridement of a subcutaneous tissue as an add-on. All of these are going to be considered packaged with the original service. We list these CPT codes because the service itself should be listed as a specific item for reimbursement to our providers and what they did, and also data tracking. But in our total package payment, it's just not going to be covered separately. The next one we look at is status indicator of A. A status indicator of A is your primary, as I mentioned earlier, for most outpatient offices and providers. This includes things like physical therapy or other ambulance fee service schedules. For reasonable cost payments, a status indicator of F, H, or L will be listed for different types of services. This first one here gives us some examples of the acquisition of corneal tissue, certified nurse anesthesia service, or a hepatitis B vaccine. A status indicator of H for pass-through services or no cost sharing, and a status indicator of L for things like your vaccinations, which also have no cost sharing. These items are going to be reasonably reimbursed based off of what it should have cost your office to obtain the items or services to provide this. You'll also notice that status indicators of B, C, D, E1, E2, M, and Y are not reimbursable. These are really for a variety of reasons, most of which include medical necessity or location issues. So for certain outpatient services, in the CPT book, you may have access to list different codes based off of what's going on with the patient, but those particular CPT codes should not be listed in an outpatient setting. Keep in mind that CPT and HCPCS can be used as both inpatient or outpatient. And while you may be a professional-based service in an inpatient setting, in an outpatient setting, these won't be used because it's not going to be medically appropriate. The next thing we look at is the OPPS provisions. This is basically saying that some of our procedures will have like an indicator of T, meaning that the status indicator says this is a multiple surgery. When performed with other surgeries, this would be allowable, but at a lower rate. So this is something, for example, when a procedure is not a standalone and there is multiple procedures at the same time. Basically, the reimbursement for the service is just about 50% for the professional service itself and the supplies needed, while the other half of your payment really goes towards things like your overhead costs to provide that service. If you're already paying for the overhead costs to provide the service, then your additional services will be at half because you've already received the overhead costs for your space. Some services won't be discounted. Instead, they'll be considered interrupted. And there's still a reduced rate for these based off of the modifier that's listed. CPT modifiers will indicate things like a surgery that's discontinued after they've started and administered anesthesia. Again, thinking about all payments as 50% for the overhead to provide that space. If we discontinue a procedure, we're not doing the actual procedure itself, so we're not getting paid for performing it. But because we already administered anesthesia, we did incur cost. And to reimburse for that cost, we get a 50% reimbursement. Modifier 74 is a modifier that says we stopped the procedure, but the anesthesia was already given and we already started the procedure. We had to stop it for some reason. Usually it's due to a medical need, like the patient's response was very poor and it would have put them in physical jeopardy. So with something like that, we're telling Medicare or whoever we're billing that the procedure was attempted and we get 100% reimbursement for that service, even though it wasn't completed. This is extremely important to report because even though it doesn't affect the payment, it allows us to attempt that procedure at a later time when it's more medically appropriate for our patient. Modifier 52 is when we've reduced or discontinued the procedure. So we haven't done the entire procedure as the CPT code would indicate. In this case, we get half the payment because we're indicating that half of the service that payment would usually be for was not done. So these fall under interrupted services, and these are considered payment modifiers. They should always be listed when listing your CPT codes first, unless an insurance company deems that it's necessary to list them in a different order. The other thing that we have under OPPS provisions are high cost outliers. This is when you really just have something that was unusual and beyond the typical services that are included and described in the procedure itself. This is usually going to require a special report or have something very unique for that provision. They have two different types of calculations, either the CMHC's partial hospitalization or other facilities. So you'll fall under one or the other. And based off of what's going on with this, you'll list a modifier to indicate the additional high cost outlier for that service. These are very rare and unusual, while these first two, this first one is the most common, and the interrupted service happens from time to time. Other provisions that can affect your payment is where are you located? So we have three different locations here, depending on the types of, two different locations and one condition that can affect your payment and increase the amount that you're paid. And this is basically a service that's going to either apply or it doesn't. The first is our rural hospital adjustment. In a specific type of rural hospital where it's the only community hospital, or SCH, there's a 7.1% increase. The reason for the increase in payment is because studies have shown, especially more recently, that providers, patients who are receiving services in an isolated area have a much higher need. This comes from a variety of reasons, ranging from patients who don't want to go into the hospital to extensive amount of services like traveling to get them to a better facility when their need is beyond what's available in the rural hospital. Because the hospitals do take on that extra cost, they get a higher reimbursement to compensate them for the increased need. Another one that's going to be unique is your cancer hospital adjustments. Now, there's been a lot of controversy on how to apply services in a cancer hospital, one of which was to have higher payments to the patients for cost shares. And that was definitely not something that providers or even the insurance wants to do. So for that reason, your cancer hospitals are going to be looked at and adjusted based off of the specific facility. And those are going to be unique to that hospital specifically. The last provision here is your pass-throughs. This is going to be where we have specific types of supplies that are really expensive, and they will be paid for based off of reasonable costs. There's different types of status indicators for these. So like your pass-through drugs and biologicals under status indicator G will get an average sales price, or what is the average cost to reimburse for this particular drug or biological. While you have others with the status indicator of H, which is a reasonable cost. So they're not going to average it. They're going to look at what should be reasonable, and your hospital may or may not pay. With both of these, you may end up paying more or less for getting the supply itself. We have a couple of examples we can look at for this. So looking at figure 7.4, which will come down here now, we have what's called a foundation of the hospital OPPS. And so basically, we're going to zoom in here. This is just saying all the things we just looked at. The first thing is a conversion factor. The conversion factor will identify the amount that's payable for that service. So that's your fee schedule amount. And then from the conversion factor, we're going to look at the adjusted amount or percentage for the area and wages, as well as the non-labor related portion. At the end, based off of where you're at and what type of facility you have, you'll have what's called an adjusted conversion factor. That adjusted conversion factor is now multiplied by the weight of your APC to give us a total payment for the geographic factors and relative weight. This is where that weight comes in place. You'll remember earlier we said 0.86 for a specific area. So you'll take like $100 at an adjusted weight, relative weight of 0.86 would be $86. Finally, you take that final adjusted conversion factor, and then you add any additional add-ons that might apply from your OPPS provisions and determine your total payment. If there are no add-ons, then there is no additional amounts. And so you would still do this calculation, but you would say the adjusted conversion factor plus 0 equals the total amount. An example of that here, does all of this math for us. So we have a conversion factor for CPT code 99282, which is an emergency visit. They have a wage index of 0.9775. So we take the total payment here. So we get the conversion factor, which is 80.78. We multiply it for the service at the so we say 80.78 at 60%, and then times the wage value. Then we add it for the non-labor service without the wage value, which gives us the total amounts of 47.38 and 32.31. Adding that together, we get a total of 79.69. Finally, we multiply that by 1.5838, which is your APC relative weight. The total reimbursement for this with your patient share will be $122.98. The patient would pay the difference between $122.98 and $126.22. Now that one, as difficult as it looked, was actually a simple conversion. A more complicated one here, we have a similar case, but a complex calculation. We have the same 80.78 here for our conversion factors, but our APC relative weight is much higher. So we have a relative weight of 74.0404. That's because this is a major procedure. And you'll notice the status indicator of J1 that we talked about earlier. The total reimbursement is $5,531. Then for our additional services with this complicated, so I can say, looking at these CPT codes, this is going to be a CAPC. These procedures are musculoskeletal services, so probably some fracture repairs or manipulations, and an EKG reading, it looks like. All of these with an indicator of N are included, and so the total reimbursement in this example is the same one from the original procedure, J1. And of course, we have here in the PowerPoint the examples we were just looking at. Let's look at one together now. This one is going to be what's called a patient connection. So we have a patient coming in for vaccination under the Medicare payment system. They're coming in for their flu shot, their pneumococcal, and they receive both the injection for the service, which is those 90662 and 90732s, as well as the service itself, or vice versa. One's for the injection and one is for the service itself. These are the charges, they're each listed, and the total prices for each one. We're going to calculate the reimbursement for this. So the first thing we're going to do is identify the APC code for both G008 and G009. It tells us here that it's 5691, and that gives us an unadjusted payment rate of $38.11. With these types of service, there is no copayment because it has a status indicator of S. We can reference table 7.1 here to see what that looked like. So an APC payment, procedure or service, multiple procedure reduction does not apply. So we don't reduce their payment at all. Now, you may be wondering, where did we get the information for the APC indicator? We use the OPPS Addendum B. To find this, you can do a quick search and say OPPS Addendum and find the information, which will pull directly from cms.gov. I've pulled that up here and pulled up the 2020 July Addendum B, which comes in your downloads. As a zip file. I'll show you here. When you have this zip folder in your downloads, you'll just open it and search for the Excel document. This is the most easy to read in your downloads. This document here is the Addendum B as released in July of 2020. These are constantly updated as we learned. I've already pulled up here to give an example of our vaccinations that were indicated here. We can see the status indicator for CPT code G0008, G0009, and G0010. And I think we're only doing 2 of these. So we're looking at the influenza and pneumococcal, which are here. When we pull these 2 up, the status indicator of S is listed for SI, and our APC value is given for these codes. We're also given a relative weight and a payment value, as well as any information such as the national unadjusted copayments or minimum unadjusted. So this is where we would find that information. Going back to our scenario, once we pull this up, we're also going to look up codes 90662 and 90732. Under 90662, just as indicated in our book, this has a status indicator of L. When we look at table 7.1, status indicator of L says reasonable cost payment. The influenza and pneumococcal pneumonia immunizations have no copay or deductible amount. And our other code, (90732) will have the same thing. Also a status indicator of L. So the only items that are going to have a status indicator payment here are going to be listed for the G codes for this patient. At this point, we're going to determine which is separately payable or packaged and bundled. Since the status indicator of 5691 is S for the HCPCS codes G0008 and G0009, this is where we're going to look at the payment of $38.11 unadjusted for each of these. Also, because it's a status indicator of S, there's not going to be a reduction in services, so they're going to get 100% payment on each of those. And that's where this 100% will apply. Because the status indicator of L for these 90662 and 90732 are going to be using a reasonable methodology, we have to look at a facility charge and multiply it by the facility CCR. For this example, we have Memorial Hospital, which is a 0.35. And since the patient doesn't have a deductible amount, that means that we will take that 0.35 to determine the total payment at 100% reimbursement. All of this is telling us is that we're basically going to find the total amount for each of these. So the first thing we do is we look at each of the codes that were listed and calculate them individually. 3811 times 60% at 1.0014 and 3811 at 0.4%. That 1.0014 is determined based off of the APC value wage index for 5691. Okay. Once we put all of this together, this particular example had a provider hospital that you weren't able to look up. So it was something that we had to pull up based off of the example itself. You would have this information available based off of wherever your hospital is. So we're just going to go off of the information that they gave us, that Memorial Hospital's wage index is 1.0014. We calculate the labor at the 38.11 at 60% and the wage index that we've just defined, and we add that to 40% of the 3811, which gives us a total cost of 3814. Since it's the same thing for G008 and G009, both of those will have the same payment. We also said earlier that for the 90662 and 90732, that the amounts listed were going to be at 0.35 or 35%. This was something, again, that's based off of your facility for your CCR and would be something that you would have available to you. To determine that, we take the total charge and we multiply it by the 0.35, which gives us the 2625 and the 4375. At this point, we're able to finally add all of these charges together to see how much would we get reimbursed. This patient for this provider hospital would receive a total of $146.28 for the injection of the vaccine for influenza and pneumococcal, which covers the injection itself and the procedure itself. The patient, however, would not pay anything. Now, if that's not clear as mud, I'm not sure what will be, except maybe practicing. As with anything in medical billing and coding, practice makes perfect. The more you practice with these different types of procedural calculations, the easier it will become. The key in determining the type of reimbursement is to really just have all of your resources in front of you and reference them each time. If you have questions on this, please feel free to reach out to me, and have a great week of learning.